part besides emergency medicine. A long time ago in a small town, I worked EMS when I went to college, and I also worked as an athletic trainer when I was in school. So the interaction between these two such important groups is a key, I think, and I'm kind of excited about talking to this and recognizing your skills and looking to see what sort of the skills athletic trainers would do to enhance each other for the care of our patients, for the most part, these young athletes. As many of you know, I work in Ann Arbor now. I work in Chelsea, which is a small town. I also work in Sparrow and Lansing. I work in Howell, Michigan, as well as Brighton, Michigan. So our group, St. Joseph Mercy, Ann Arbor, and Sparrow Hospitals are all with the same group that I work with. So this actually is an important slide to me because this is where I went to undergraduate, Alma College in Alma, Michigan, small town, Gratiot County. We had one ambulance service. Oops, let me turn that down. One ambulance service, and we had the small college. When I was in college, I used to go to some of the high school games, like I know most of you have to do at some time or another in your area, likely. And I think the people in the bigger cities have doctors on the sideline and have EMS and hospitals within miles. I'm sure some of you guys, if you do sit on the sidelines of a game, may have 20 miles, 50 miles to get to the closest hospital. I had that once with one of the injuries I took care of as a trainer. So I think this will give you some ideas on what to do in some of these emergencies when you have a life or limb-threatening injury. So a couple of things I'd like to sort of talk about today are the cooperation between the trainers and EMS. I think it's good nowadays. When I started, it wasn't so good, and that was about 30 years ago. We're going to talk about neck injuries, which you guys are experts at, but we're going to talk a little bit about some of you that don't deal with helmets all the time. So that's an important thing to know. Head injuries, you can't read the newspaper or sports medicine literature without hearing about that. And I'll talk about some of the things that are new to sports medicine, head injuries, and some of the things may be coming, and what we'd like you to have for us when you come to my department. Ankle injuries, a common thing, knee injuries, and a couple other little important things we'll talk about today, okay? So as you guys might know, I like to have cases that we'll talk about now, and then we'll kind of go over at the end. So our first case is a 19-year-old female who was playing soccer. Soccer is a huge sports medicine head injury problem for women especially, but men as well. But since women don't play football as much, this is one of their biggest head injury problems. She was hit in the right frontal parietal area by another kid. They headed each other like the picture shows. And hopefully, as EMS people, I know that most of you love gross and disgusting pictures, so we'll get a lot of those in here today if you didn't preview my lecture. This student athlete was unconscious for about 20 seconds. She has amnesia. She's got a right frontal scalp contusion. So what are you going to do next? The second case is one I see all the time. He's a 17-year-old football player. He had a hard helmet hit to his helmet from another helmet. He's got some stinging and lightning down his arm. He's got some neck pain. And you're called by the athletic trainers or the student trainers or whoever gets stuck doing a little game to come out and help. There's an 18-year-old football player who was tackled and had his knee twisted. He's got pain on the outside of the knee, and as you may see there, he can't really walk on it. He's got swelling. So what are you going to do for him? And this guy, I don't even know where to start on him. The fourth one is a 22-year-old college athlete who jumps up for a catch, lands a little funny on his knee, and his knee looks a little funny now that he's landed on it. So where do you go with him? Next, we have a 22-year-old college basketball player, jumps up for a rebound, lands funny on his leg. His knee hurts as well, but this is a completely different injury. And then what are you going to do with him? And then we have a professional hockey player, and this is a true story, and that's an actual photo of it, and I was at the game. This is a 25-year-old hockey player who just finished his shift, went to the bench, and collapsed. So what are you going to do there? You may not be with the Red Wings, but you may be at a hockey game or a football game where this happens. So we're going to talk about this as well. So one thing I want to stress about this is that we're in ER, we always talk about being teams. We have the doctors, we have the nurses, we have the PAs, we have the nurse practitioners, we have the techs, and we even have the clerks. And so our team doesn't work together unless we all work together. The same thing with sports medicine. You'll have your athletic trainers, maybe. Some of you may not. The smaller areas don't. Some of the schools that have more money do. You guys may be the only providers on the sidelines. There may be student trainers, as in some schools do, and then you may be lucky enough to have a sideline physician, physician assistant, or nurse practitioner, as we do in where I work, okay? So I'd like to start with head injuries, and head injuries are really in the news all the time. Some of the long-term effects of the head injuries, it just can't be, are just devastating for some people. They don't show up right away. We're not going to talk about that part of it. We're going to talk about sort of the acute care. So what sports do you have head injuries with? Well, almost any sports, but the key ones are hockey, soccer, football, basketball, rugby, gymnastics. We have a lot of neck and head injuries. I was a pole vaulter in college. I had no head injuries, but they thought I was a little nuts for doing it. We have diving injuries, and then the new sport around our area, lacrosse, even though it's an old sport. So let's talk a little bit about a concussion. So a concussion is a Latin word to be shaken violently. There's the brain gets basically sloshed around. There's small little vessels in there that can be torn. There can be bruising of the brain. There can be just a concussion. And I could talk to you for hours about concussions. Some people have little symptoms right away and can have just awful symptoms afterwards. You can have somebody who's completely amnesic. There's one story I have about a physician who was in a bicycle accident, and she had an MRI, she had a CT, she had a PET scan, every scan you can think of on earth. She never had any abnormal findings, but this physician couldn't remember anything more than 15 minutes the rest of her life. When she drove in a car, she had to set a timer with a little yellow sticky note on it that said where she was going, because she'd be driving in about 15 minutes, she'd forget where she's at, and she'd be lost. So concussions can be just awful without having any findings. So the CT scan may not be, as exciting. So that's why I tell the story, because I want to impress on you how important some of the initial protection that we do for these kids are. There's about 300,000 head injuries a year, and that's the ones reported. I'm sure if your kids played, or if you played football back in the 80s and 90s, you bumped your head and couldn't, maybe went to the wrong huddle in football, and nobody paid much attention to it. So now the trainers and hopefully you guys, if you're on the sidelines, notice these things and can grab these kids and grab them out. The coaches definitely are more cognizant of this now when they used to be. Just put them back in. So they're liable for this, but even more important, this can affect the kids. So the statistics show about 3 to 8% of high school football players are having concussion. That's a lot of head injuries a year. And up to 19% of all players in contact sports are having concussions. So the symptoms can be wide. It can be confusion, amnesia, foggy feeling, their head's stuck and they're shaking their head. In the old days, some were sniffing the ammonia capsules. They may be disoriented. They may have this vacant stare. I mean, there's a whole list. It may be sound sensitive, light sensitive, dizziness, fatigue, and these can be acute. These can be chronic, and unfortunately, some of these can be lifelong symptoms. I've seen these in kids. We get a lot of something called post-concussion syndrome, where again, people don't have any findings on any physical exam or any imaging exam, but boy, are they disabled from this, and it's a true thing. I know because I've dealt with it quite a bit. And we are lucky enough to have a concussion clinic in our area, which I can see some of the follow-ups. So you can see how devastating these injuries can be. The biggest thing is preventing them, which has nothing to do with us, but we can try to minimize them from our job, your job, and my job. I still like the old Glasgow Coma scale when I'm looking at a kid, and I really happy when you guys bring one in, which you always do, with a scale, because then I can see where the kid's at the time, and then we can see examining, because one of the worst things that you can see and one of the most devastating outcomes are what they call the talk and deteriorate. So that's the kid who's on the sideline, who banged his head. He was dazed for a little bit, or she was dazed for a little bit, and they seem to be fine for a little bit, and then they quickly deteriorate. And there's a high incidence of epidural hematomas, subdural hematomas, and a poor prognosis with these. So if you can give me a GCS on the initial exam, when you see them on the sideline, and even yours compared to the trainer if you're coming from a distance, and then I can do it again, it can help us kind of predict a little bit how they're going to do. Now, the GCSs of 8 and less, are devastating, and 25% of those do need some neurosurgical intervention. The 8, the 9, the 13s still have ones, but again, the talk and deteriorate are the worst prognosis. And then, you can have a GCS of 15 and still have a significant head injury. It just goes to less neurosurgical intervention. So more of the bruised brain, the concussion, more than the bleed in the head. So that scale, as simple as it is, can really be helpful to me in the emergency department and my people, that you can help us with that, okay? So head injuries, there's actually laws in Michigan that tell you what you can and what you can't do, okay? So in Michigan, if they truly have a concussion, there's a whole protocol they're supposed to go through, which it's kind of complicated. It'll take a lot of time. I'll be happy to send resources to anybody, but they're not supposed to go back in the game. If the coach ever would ask you, Johnny got a concussion, maybe he was out, maybe he wasn't out for a few seconds, I would never let him back in the game. So Johnny and Susie are to be excluded from the game, and there's no exceptions to this. As far as transporting him to the hospital, if they're much less than 15 after a head injury, I would bring them in. I would strongly encourage the parents to have you bring them in so we can take a look at them and make sure they don't deteriorate in the ambulance or on the way to the hospital. So I would encourage that. And as I know, like you guys, a lot of people refuse it, but I would tell them they need to go right to the closest hospital to be seen. And in the ED, we talk about CAT scans a lot. And if you read any of our literature, which you may see, we talk a lot about not doing CTs in young people unless there's, what we're looking for is not a concussion, because a concussion won't necessarily show up on a scan. We're looking for what needs an intervention, what needs a neurosurgeon to see them. So there's 2 rules we use, is PCARN and then the New Orleans head injury score. And if you guys want those, I can send them out. I forgot to include them, but they're pretty easy to do, and they kind of give us, it's what we actually use right now to decide whether a child or 18-year-old needs a head injury. The 80-year-olds, we don't use that, but the 60 and under ones, we use this, and it works pretty good. It limits the number of CTs. Looking again, our goal is to look for stuff that needs neurosurgical intervention, not concussion. Looking for a concussion is a whole different thing, like we talked about, because there does not much showing on the CT scan. Now, after the ED, so Johnny comes in, his Glasgow's 15, just to give you a perspective, state law limits me as an ED provider to let this kid back into the game even within the next week. It is against the law in Michigan for an emergency medicine provider to clear a child for participation. So you got to understand the rules and the laws, and so I'm a little bit hamstringed too, which is okay with me. They have to follow up in some big areas with a concussion clinic or their family doctor. In the smaller areas, their primary care physician can clear them, and there's a protocol with them. The better schools actually have pre-season screening of the brains, and so they can see subtle differences. But the state law does not allow pediatricians in the ED, ER physicians, PAs, or nurse practitioners to clear a kid for participation, just to get a perspective on how important this has been. So why don't we want these kids to come back in the game? Why, in the olden days, I remember sitting on the sideline and one of my buddy comes up to me after he got clocked in the head because he always tackled with his helmet. he said, "Hey Jeff, what school am I at right now?" And I said, "You're back at Alma," because he used to go to another college. He says, "Well, okay, I'm ready to go back in the game now." Well, there's reasons we try not to do that. He has decreased judgment, so he may make a mistake where he hurts somebody or hurts somebody else. He may have decreased stability. He may have he may be off balance, uncoordinated. They can hurt themselves doing that or hurt somebody else by getting some of these 400-pound linemen falling on them. The re-injury rate is high. Within 10 days, it's 4 to 6 times normal. And there's something called second impact syndrome where somebody gets a head injury and they may have mild symptoms, but the second injury can be, I don't have the number, but much worse. So 2 head injuries in a short amount of time can amplify the symptoms and cause them long-term problems. And then, again, repeated head injuries without giving your brain a rest, it can cause long-term cognitive difficulties. So the idea in any of these head injuries and why they don't let ER people send a kid back to the game or even back to participate within the next few days is we got to give the brain a time to rest. You know, when you sprain your ankle, you got to let it rest. You got to let your brain rest. And sometimes that means you have to sit down in a dark room, not watch TV, not read a book, rest your brain. We're even telling kids not to go to school for a few days. Certainly TV, computers, cell phones, we're telling them not to do those things because some of the lights and some of the other things can cause problems that will keep going in the future. So it's really an important thing to know. So that's a little bit about a head injuries. We'll talk some more and we'll go review some things. Some of you back in 1999 remember Detroit Lion Mike Utley. He was a linebacker, as I read, a defensive lineman or linebacker who was blocking a pass rusher, jumped to block the pass. He was offensive lineman. The defenseman came down, knocked him off balance, and he landed on his neck. He couldn't move his arms. He couldn't move his legs. He was basically paralyzed on the field. He could move his hands, and there's a famous picture of him with the thumbs up, but he had a severe neck injury, okay? So our goal, as you guys know, I don't have to tell you, is to try to limit the neck injuries. I can come back and talk to you about my feelings about neck injuries in other areas and how we should protect their neck when we're transporting them. I was at a level 1 trauma center, so we got people off the board right away. I take the collars off for a lot of people who are awake and alert right away, but that's a different game. But in football, you want to mobilize the neck and you want to protect them. This is where one of the cases now where I like to see them on a backboard. For the most part, I like to see them on the backboard when they get there and I take them right off. But these guys, I don't take off right now, okay? So neck injuries, you can see there's 10 different things that can cause neck problems. Everything from a dislocated neck with paralysis, a lifetime of, horrible life to just minor, numbness and tingling, quadriparesis. So a small neck injury can lead to any of these or very minimal problems, okay? So neck injuries on the field, this is one of my little run-ins I'd ever had with EMS when I was an athletic trainer. We never had any problems, but this was 30 years ago, and I don't think it happens very often. But we had one of my football players hurt his neck and had probably a stinger back then, which is just an irritated nerve in his neck, but he was having some numbness and tingling. So the physician, this was at a college, the physician assessed the patient on the sideline, and then he had EMS come out in the field, and we backboarded him and placed him on the board and taped him down. And he said, leave him like this and take him to the ER. Well, EMS felt at that time, and again, this is probably different, but they felt that they were taught to take the helmet off, and that's just not the right thing to do. These helmets and shoulder pads are designed specifically to be left on until we can clear them. The masks, the face masks, which we'll talk a little bit about more, the face shields are designed to be taken off quickly so airway is not a problem. I've seen intubated football players with the helmet still on, the shoulder pad still on, but they have the face mask taken off. So leave the helmet on unless there's something rare and you guys all agree on the sideline it needs to come off. It takes about 4 or 5 people, which I'll show you a little bit about, to get the shoulder pads off, because once you take that helmet off, the neck extends or hyperextends, and you got an whole set of problems. So the NCAA and the National Association of Athletic Trainers, as well as the American College of Orthopedics, recommends the collar left on, I'm sorry, the helmet left on, the shoulder pads left on until a CT or an X-ray can be done to clear the neck. MRIs are harder to do because of the straps, but the CT will get through there to get you clear, and that's been more our standard of care here. So face mask removal is not hard. They're designed to come off quickly. You can actually take a knife and cut the plastic that holds the shield on. Some of the helmets have these little tweezers you can see up here that will pull the rivets off. These are called a trainer angel. Some of these will actually just pop off if you do it just right. A cordless screwer, which most of the equipment managers have, can pull one off in about 2 seconds. And then I've even seen a bolt cutter, but that's not one that normally needs to be done. That's sort of the rare thing, but it is still something you can use. So you want to leave it on, and you can see in this player, his face mask is off, he's backboarded, and his head's blocks are up, but you have access to the airway if you need it. Okay, so it's really important to try to leave those on. Only remove the helmet unless it's agreed upon by everybody on the field, and this is one where I'd want the physician as well as everybody else. You have to take the pads and the helmet off as one unit, and you have to practices. The trainers practices. You guys may even practice it. In the hospital, we don't practice it. I'm one of the few that know how to do it correctly, but this is important because we don't want to make what could be a fixable injury, a non-fixable injury with a quadriplegic, okay? So what you have to do, and I'm going to show you a video kind of how I do it. I apologize if my video doesn't work very well. We tried it and it worked earlier. So you have to take the pad and the helmet off together. So what you do is you cut the jersey and the sleeves. So you're just taking pulling it off. You have to cut the shoulder blade straps. One person the whole time is holding cervical traction. You cut the chin strap. You don't unsnap it because that can sort of change the angle. There's ear pads in those, so you have to pop those out. They're not too hard, but you have to know how to do it. You have to release air. A lot of these helmets now have little airbags in them, so you use almost like a blood pressure cuff and a ball, when you put air in your basketball to let the air out. And then you have to hold the patient, you have to hold the kid in the waist, so you have to actually lift him off the ground to have everything in a neutral position. And then somebody removes the helmet and the shoulder pads all in one motion. Okay, now we're gonna try this. We'll see. It's about a minute and a half. I apologize if there's a problem, but you can always look at it later.
We want to be ready if a Chiefs player, a high school player, a Little League player comes in with enough of a head injury that we have to manage their airway and while protecting their cervical spine. So this training is meant to show people the proper removal of a face mask.
You can see the helmet, the shield pop off.
Of the equipment and what order it comes off in.
And they're cutting the sleeves, they're cutting the shoulder blades, or shoulder pads. So in the middle of the shoulder pads.
Because we don't know how to manage this equipment.
They're cutting the chin strap.
We injure the cervical spine by doing things out of proper sequence. Theoretically, I'm not sure we know exactly, but because in point of fact, somebody who injures their neck in a collision on the field, probably whatever injury they're going to have, they have at the time of impact. But we don't want to take any.
So you see they pull that off with the collar traction being held. And then this is a little bit different technique, but then they remove the shoulder pads. And see how they don't really move him much.
You do, whether it's putting an airway in, taking off the shoulder pads, taking off the helmet. We want to maintain the alignment because we want to take no chance of having any further injury to the spinal cord.
All right. So that wasn't the best view for doing this, but the ones I could find weren't very clear. So, uh-oh.
It's a 4-person evolution.
Okay,
Right? If we're going to take the equipment off somebody, it takes 4 people. So if you are in an ambulance and you get dispatched by yourself, even if it's
back to PowerPoint. Okay. So it gives you an idea. There's a couple different methods. This wasn't it was the easiest one to see, but not necessarily the best how-to, but there's some great ones online. So to review our head and neck, we're going to talk, we talked about the Glasgow Coma Scale, which will help us. Never let a head injury go back on the field, even if the coach asks you to. Hey, they need to be assessed by their pediatrician, their family doc, or they need to be brought in the ER. Unless their Glasgow Coma Scale is completely normal, bring them to me, bring them to us. Neck injuries, never take the helmet off. The face mask can be easily removed, and the helmet is designed to be stabilized, okay? So that's one of the important parts and the one where we can cause damage. So let's go on now to some orthopedic injuries, something that's always fun, some beautiful pictures for you guys. So when you guys get called to the field or you're at your kid's soccer game, they say they knew that you're an EMS and paramedic, or you're a EMT specialist. They even have those anymore, or EMT. And they say, can you look at Johnny's ankle? So when you see somebody with an ankle like this, you know what to do. But when they ask you to look at it, I'm not asking you to diagnose him, but this will help you get an idea sort of where it's going to go. So I don't need to show you that, we talk about inspecting it, touching the areas, looking, is it aligned or is it deformed? What's the range of motion, and are the ligaments stable, okay? I don't expect you to know all these, but you can really help on the sidelines if you can see, because what happens is by the time they get to the hospital, there's a lot of edema in there, and you can maybe tell on the sideline. And when I was a trainer, I could tell better on the sideline than the physician in the ER could tell, because I saw it before all the swelling went up, and the ankle was like a balloon, or the knee we'll talk about in a minute was like a balloon. Okay, so you can give me an idea of what's going on. So you look for edema. You want to document for us where it's tender. Are there open wounds? Is it an open fracture? That's a whole different category for me to call orthopedics for. Do they have a good pulse, and do they have refill of their toes? Can they feel their toes? I mean, are their toes red, and you pinch them and they turn white, and then they quickly turn red, so you can see they're getting good circulation. So we want you to document those things. This is the anatomy of the ankle. The foot's really complicated. The ankle's not. It's more of a, it's a hinge joint, and it's got some lateral internal external rotation in and out. So how can they move it? What's limit and what hurts always helps me when we look at them and get an x-ray. The range of motion you can see is pretty limited. You can only flex up 20 degrees. You can plantar flex towards the toes. About 45 degrees. The most common injury is what we call an inversion injury, which is 30 degrees, where you turn the ankle in. Eversions are a little less common, and you can see there's only a 20 degree range of motion there. So the ankle doesn't have a big range of motion. So if it doesn't look right, there's probably something wrong there, okay? So you want to try to document, does it look normal, does it not, okay? So some of the things we look for, so we've looked at inspection and palpation. You're looking at the alignment, the range of motion, both them moving it and you moving it. Does it hurt? Does it not hurt? What we do in the ER and what you can do on the sideline is called anterior and talar tilt. So the anterior drawer is where you sort of push down on the ankle and pull up on it, and you're looking for torn ligaments, the deltoid ligaments in the ankle. So if it moves more than you think, they probably tore some ligaments quite significantly. And as you may know, a torn ligament can sometimes be worse than a fracture. The talar tilt checks, the joint stability of the ankle too. So you kind of rotate the ankle while you push on it, okay? I also do a heel tap. So what I do is, like the first picture on the anterior drawer, I hold the ankle and then you tap on the heel, and that gives you a sense that there's a possibility of a tib-fib fracture. Another important one you can see, especially if you get called to sort of a weekend athlete kind of thing, where, the 40-year-old guy who's a little overweight trying to play hockey or football with his buddies, gets an ankle injury, one thing that you might test is a calf squeeze test, which you have them kind of lay on their belly and hang their foot down, and you squeeze their calf, and you see that their Achilles is intact. So if you squeeze their calf and the ankle or the toes kind of go up, you know the Achilles in place. If you squeeze and there's no movement, and then if you feel down their Achilles tendon right near their ankle and you feel a big hole there, then you know you need to splint them and bring them into the ER because they ruptured their Achilles, and that's a common injury for weekend warriors, okay? So once they get there, you've gotten these. One of the things I do is called the Ottawa ankle rules. And again, just like CAT scans, we try not to order x-rays on every single person. And this just gives you an idea what we'll do. And this can help me if you have documented Ottawa rules, but I wouldn't necessarily expect it. So what we're looking for is, do they need an x-ray or not? So do they have bony tenderness on the medial or lateral part of the bone, the ankle bones, or the lateral malleolus or the medial malleolus? Can they bear weight immediately after the injury and then in the EDAR? And then there's one there about the foot, which we'll have to get to some other time because we don't have a lot of time. But the foot's similar. We're looking for tenderness and we're looking for weight bearing, okay? So let's say you come in and you see that somebody's got a deformity. We don't generally recommend reduction on the field, but I know that some of you folks probably work maybe an hour away from the nearest hospital. So when you see a dislocated foot or ankle, probably more an ankle, if you have a good pulse and you have good refill and they can feel their toes, just splint it in place. But there's an occasion where, and I had one of these, and when I did sports medicine, where the kid did not have a pulse. He got hit right in the tib fib. He broke it. It was bent up like one of those pitchers, and he had no pulses, and he couldn't feel anything. So we had to basically just pull some inline traction on his ankle and then splint him. And luckily for him and for us, he got his pulse back. So I'm only asking you to do that when there's no pulses, or they're going to lose their limb unless you do something. So pulling some inline traction will help, and then splint them with one of the splints we'll talk about. But document the pulses weren't there and document the pulses were there if you can. And then what I like to see is a splint. As far as splints, you guys are probably better than that. I love pillow splints. I think they're great. I can examine the ankle without moving it a lot or removing anything too fancy. So I really prefer pillow splints on ankles if possible. You guys have those vacuum splints sometimes. Those are great. And then sometimes just the old-fashioned board splints with the swath, with the ties around it. So anything you can find or use to immobilize it so we get a better look at it, okay? So again, to review the ankle, check the range of motion, check some strength. Is it stable? You can do that if you feel comfortable with it. Where does it hurt? What are the special tests, the Achilles tendon especially, and what are you going to do? You're going to emergently pull some inline traction if they have no pulse and no sensation, but otherwise you're just going to splint it in place and bring it in so we can get an x-ray. It's not always easy to tell what's going on without an x-ray. The knee's a little bit more complicated, and it's a little more fun, and it's really where sports medicine athletic trainers really kind of enjoy being a diagnostician, okay? It's fairly simple in the bony structure. You can see the kneecap, which, comes into play significantly in some spots. The femur above, and the tibia is mostly the knee below, and then the fibula is kind of hanging out on the sides. Where we see a lot of, or most of our injuries aren't fractures in the knee, it's going to be ligamentous injuries. So the lateral and medial collateral ligaments run across the sides of the knee. The anterior and posterior cruciates cross the knee inside, and then the meniscus are sort of like, whoa, sorry about that. They're sort of like the padding right here. Sorry, I will. So this is the cruciates, the meniscus, and the lateral and medial collateral ligaments. All right, well, that doesn't work very well. All right, so again, basic physical exam, you guys all know and learn, inspect it, look for areas that are tender, look for swollen areas. The range of motion on the knee is limited to basically flexion and extension, okay? And it doesn't extend much past straight unless they're a little bit torn ligaments. The range of motion, you want to test it. Can you push on my hand as I hold pressure against it, or can you not? You're going to check the ligaments, we'll talk about in a minute, and the patellar femoral joint. So you can give me an idea what's going on or what you think's going on when they come in. So you can see the flexion, the extension is 0, full extension down here. And then the flexion is 120 degrees, okay? So there's an idea. Some of us older guys who are less flexible may get 90 degrees. That's about where I'm at, okay? These are the tests. We'll talk a little bit about more of them. So when you push on the patella, you can hear some grinding, or you can see that the patella is not tracking well. We can see that in jumper's knee or a dislocated kneecap. The anterior cruciate ligament, ACL, you hear about the football players getting that all the time. You do what we call posterior jaw or a Lockman. We'll look at those quickly. I wouldn't expect you to know those. PCL, Steve Eiserman played most of his career with a PCL tear. It's not as important. It kind of helps limit the posterior movement of the lower leg. But that one you can do anterior jaw for ACL, posterior jaw for PCL. The medial collateral ligament, you do valgus stress. The lateral collateral ligament, you use varus strep. And then the meniscus, the padding, you use the Apley's grind test or McMurray's. So those are the ones I use in the ER, and the sports medicine guys will use on the sideline. But again, you may not always have that luxury for that help. So just to give you an idea, so with a varus test, what you're going to do is you're going to stress the ligament by putting pressure at the knee, on the inside of the knee, and push the ankle in and the knee out, and that'll tech the lateral collateral ligament, okay? If that bends like you shouldn't expect it, and you'll know it when you see it, then it's a torn lateral collateral ligament. And the opposite we do, we push on the outside and pull the ankle, push inward on the knee and pull the ankle out, and then the medial collateral ligament we stressed, okay? So they'll give you an idea what they're torn. And again, if you can give me an idea what's torn on the sideline before the swelling starts, I can be more effective in treating them. And then here's a couple more. Lockman, you just hold the top of the knee and pull it out. The anterior jaw, you flex the knee at 90 degrees and you just pull out or pull towards you. And then the posterior jaw test, you're pushing in. So that checks the ACL and the PCL, the lateral pivot shift test, and the McMurray's test sort of check the PCL and ACL. But the Apley's, you can see the guy down here, he's just pushing on the knee and grinding it. And if it locks or they have a lot of pain, they probably tore their meniscus. I find that the easiest one to do. So we talked about the Ottawa ankle rules. Dr. Ian Steele in Ottawa at McMaster's University has come up with the Ottawa knee rules as well. So the Ottawa knee rules, and again, this is looking for who needs an x-ray. There's actually there's an Ottawa head injury or Canadian head CT rules as well. So what we look for is age over 55, tenderness at the fibular head, isolated tenderness to the kneecap, can't flex up to 90 degrees, and they can't walk 4 steps. Pittsburgh is just another one I thought I'd add on there, and it's similar in the same respects. So a lot of people will come in, and this is one that's kind of cool, and you guys might even be able to fix on the sideline. I get people who come in and say, I dislocated my knee, and 99% of the dislocated knees are actually patellar dislocations. You can see on this person, their knee is pushed to what looks like to be laterally, their kneecap over here, and it's pretty easy to fix sometimes. Sometimes I have to sedate them because they're having spasms or more than that anxiety. But basically to relocate it, you fully extend the ankle and put it in a neutral position, and you just sort of push traction, gentle traction medially in this case, and it'll pop right back in, and their pain will actually go away almost immediately once you get it in. So that's not hard. I give it one try maybe if you can see it's lying on its side, which is pretty obvious in some cases, or puckered up a little bit, which I'll show you a picture of later. But yeah, that's something easy to try that you can fix, okay? A knee dislocation is completely different here, okay? A knee dislocations where basically you tear everything. You disrupt almost all the ligaments. The problem is you can tear the blood vessels as well as the neuro system, the nerves, okay? These are devastating for the patient. Imagine all six of those ligaments, all six of those ligaments and meniscus completely torn, so you can see. But the most important things, those can be taken care of. The most important things are they lose blood or have they lost their nerves, okay? So this is what a knee dislocation looks like. Now, surprisingly, a lot of them will reduce themselves on their own, okay? So I've probably only seen one of these in about 30 years that I've seen like this. Most of them will relocate on their own, but they're still devastating, and you cannot rule out a vascular injury. So these definitely to be brought in as soon as you can, okay? So this is what it looks like when we do an x-ray, and you can see you had to tear every ligament and meniscus in there to basically go this far. So if possible, if they don't have vascular compromise, you just splint them in place, you give them drugs if you got them, and you bring them in. But sometimes you'll find one on the sideline that has no pulse, they can't feel anything, so you need to do something, okay? So splint them as comfortably as you can if you can do that, but if not, you need to think about relocating it, okay? So even good pulses don't rule out a vascular injury, okay? So you can tear a popliteal vein, you can tear arteries as well. So please be cognizant of that, and even if you relocate it, understand that there's bad stuff that made it happen, okay? Or even if they did it themselves, relocate it spontaneously to themselves. And almost every one of these, I can't think of too many that they wouldn't fix, but almost all of them need surgery, okay? So here's a quick little a video on a relocation of the knee. It's not always this easy, I'll tell you, but occasionally it is. So let's try this again. It only takes a minute, I think, to do this, if I can get it to work. And I think these just emphasize what.
But there's also a very other simple but important shot here, and that's this 50-50. It's a good confidence.
All right, skip.
So I'm
going to forward it ahead here because they're just Dopplering it and some other things, checking the pulses with fancy machines. All right, so there's a dislocated knee. We'll make it bigger. You can look at these again on your own later. So you can see the orthopedic doctor's got the ankle.
He's got pain medicines already on board.
And he's sedated, so there.
Are you awake still? Are you awake? No, I think he's out.
So
what are you doing? Explain to us.
Just pushing on the femoral condyles here.
You can see it popped right in.
Oh.
Okay.
I felt it.
Now I'll tell you that the one I did wasn't anything like that. And then you immediately get them immobilized, okay? And bring them into the hospital. Because, again, these are quite devastating, okay? So these are what they can look like, and that's what it looks like when it's better. So remember, with the knee exam, you look at the ligaments, you look at the bones, but the truth is the bones are not broken very often. It's almost always ligaments. Injuries, patellar dislocation, maybe you can push a little bit on. If you hold some steady traction on, they'll pop in and they'll be really happy and then not in pain because they get quite spasms from the patellar ligaments and the quadriceps ligaments, okay? And then the knee dislocation, you don't see them very often. Most of the time they still have a pulse, but occasionally if you are losing a knee, you're losing a leg, you may need to do a little pressure like that, okay? And again, treatment will be icing, elevating, splinting, and bring them into the hospital, okay? Now this is a famous basketball player, and it's going to bring us to our next, our next case, and this is Glenn Bias? Just a second here. Hank Gathers, I apologize. He was a basketball player. He's playing basketball right now in a game. We're going to move it ahead a little bit. So you can see him standing there. He's right in the center of the screen. He just went for the ball. He's just standing there and he collapses. And it almost looks like he's seizing. And this was a long time ago. He tried to get up. So we'll stop it there and go back. But he tried to get up, he collapsed, and he went into full cardiac arrest. Now, this was a while ago, but the sad part is there was an AICD there that they didn't use. They did CPR on the scene. If you watch the whole thing, they took him back, and he passed away. He was supposedly one of the great he would have been a pro, and this happened when he was in college. So this we're going to talk about is syncope, not necessarily arrest. So syncope is a big problem. Now, history post-exertional. So if a guy runs a marathon and then at the end of it he collapses, that's generally less concerning. It's usually a benign problem. It usually occurs after exercises. They don't warm down. They have decreased venous flow, so they sort of get vasovagal and they pass out. Okay. Most of the time they're dehydrated. Those aren't the ones that I'm so much worried about. Those you'll see commonly. That's the most common one. The one that scares you is the kid's running in the race, the kid's playing in the game, and all of a sudden he collapses. He may go into arrest, he may not. That's less of them. That's 1% to 2% of them. And these are the kids that have structural problems, or the adults that have structural problems, or have an MI, or have an arrhythmia on the side of the, they're playing beer league hockey and they collapse and they go into arrest. And that's why these AICDs you guys carry and the ones they have in the community are so important, because that's really what saves them, as you know. These could potentially have hyponatremia if they ran a marathon, or they really in a lot of waste in fluids. If it's really hot out, it could be heat stroke as well, but a lot of these will end up having structural heart problems. Okay, so you got to start like you do with all your syncopes or all your people that pass out, whether they're athletes or not. You got to do your ACLS. If you can get an EKG and see an arrhythmia, please do that. You may consider putting your AICD on them just to make sure. You bring them to us, you bring them to the ER, and what we'll do if they do seem to stabilize, which many of them will, is we'll get an echo. We got to look at the structure of the heart. Is it big heart? Is there dilation in certain areas? Is there certain areas not pumping? Do we need to get an EKG to look for the arrhythmias? If you can't, arrhythmias will cause these. And believe it or not, syncope from ectopic pregnancies in women I've seen before as athletes, and that's one you don't want to miss, an ectopic pregnancy, okay? If they pass out, especially during the game, do not let the coach try to talk you into it. You get called to the sideline, the kid's blocking and he passes out, or he's in a basketball game. Don't let the coach try to talk you into it, especially during the game. These kids have that 1% of these kids will have the 1% kids who have it during participation will be the ones that will have bad outcomes, and you'll end up doing CPR on them, and it's really not what you want to do on a kid. Okay, I know that. So the study in cardiac death, there's many reasons, and most of them, when we do the echo, we'll see hypertrophic cardiomyopathy, dilation of the heart. You may see prolonged QT syndrome, which is where the QTs are prolonged, so they go into arrhythmias easily. There could be stenosis. But again, the big ones is the cardiomyopathy is where we see it. It could be aneurysms, could be pulmonary embolisms, could be ectopics. But the most common one for this is the hypertrophic cardiomyopathy. You don't need to know that one, because I may not find out it in the ER, but you just need to know they can be devastating and die, okay? So this was a big cause of non-traumatic deaths. The kids that get whacked in the chest sometimes with a baseball will go into arrest. So ABCs, again, it's led to 126 deaths in 10 years, 34 collegiate deaths in 10 years, because I think they have more equipment there. And then this cardiac etiology is the most common cause of these deaths, okay? Again, sudden cardiac death, you got to go ABC, AID, transport, okay? The drugs I don't think work as well as AED, okay? So in review, so the pearl. So make sure you take a pulse, make sure, hey, I was just hibernating. Don't you guys ever take a pulse. So pearls. I like to use pearls. Do not return an athlete to competition the same day after even a transient head injury. I'm not even going to say transient concussion. If they look fine, they act fine, they shouldn't. We've talked about all those potential problems that can happen, okay? Keep the helmet and shoulder pads on. You can see how many people it takes to properly take it off. So keep them on and wait till we can image them in the ER. The face mask is really easily removed, okay? Ankle and knee injuries, splint them in place. Get me a good physical exam if you can. Make sure there's pulses. If there's no pulses in the ankle and knee distally, you may want to think about relocating so they don't lose their leg. And as again, you guys are rural, you may not be close to an ER. It may be a 20, 30 hour transport, so you need to decide what to do there. If it's right next door, obviously not. Syncope during excuse me, during the activity needs emergent evaluation. There's a high risk for cardiac disease. And then sudden cardiac death, the kid that just, the player, the young athlete running the marathon who just collapses even though he was winning, you know, ABCs, AED, those are the main things, AED, okay? So Ensign Johnson suddenly discovers he's the only one in red. And if you watch Star Trek, you'll get the joke there. So let's go back quickly because I over-talked. So let's talk about our 19-year-old female playing soccer. She gets whacked in the head by another player. She's unconscious for about 20 seconds. She doesn't remember the event. She's got a little head injury or a bump on her head as well as probably a concussion. What do you do next? You do your Glasgow Coma Scale. You talk to her for a little bit, and then you talk her parents into bring her into the hospital because she is going to need evaluation, and she's going to need follow-up, and she's not to be let back into the game, okay? Number 2, you got the linebacker, hit helmet to helmet, intermittent stinging down his right arm. He's got neck pain. He's got numbness tingling with that stinging feeling. He's probably got something benign called a stinger, but in this case, when there's numbness and tingling and you don't have a way to image them, you backboard him, you bring him in to see us, okay? Come onto the field and bring him in. The football player was tackled, twisted his ankle, pain on the outside of the ankle. In this case, there's deformity. He can't walk. It's swollen. You know, you splint him in place if he's got a good pulse, okay? You splint him in place, you put a bag of ice on him, and you bring him in to be seen. Number 4, college athlete jumps for a catch and lands funny on his knee. This looks a little bit like a dislocated knee, though it's probably a proximal tib fib fracture. So on this one, again, you're going to check the pulse, you're going to check the sensation, you're going to try to splint it in position. But again, if there is no pulse, if there's no sensation, if there's poor refill, you're going to consider, well, how far is your transport and do you need to try to straighten it out a little bit, okay? And then here's the opposite. I dislocated my knee, but you can see his right kneecap up here. Looks like it's dislocated. He jumped up from rebound, landed a little funny, and now his knee looks good. You'll probably still want to bring him in to get checked, but you may put a little bit of traction on that knee, push it kind of medially, and you may be able to relocate that one. This is Yuri Fisher, who passed out after playing a game. He had a syncopal episode, and he ended up having a hypertrophic cardiomyopathy. He has an AICD in now. He's now a scout because he can't play ever again, and he was only 25 years old. But he actually had to have CPR, and he had an AED used to bring him back. And he's neurologically fine, but he can't play professional anything anymore because of the myopathy. All right, so I know that was quick. It went a little longer than I thought, but it was new, so I'm not sure. If you guys have any questions, we will try that. You have my email if you wanted to ask any questions later. I can give you resources for, you know, more complete knee injuries if you're interested, and I appreciate your time and attention, unless you're all sleeping, and I will sign off for that. Thank you.
Jeff, can you hear me?
I sure can.
Okay, good. I just wanted to double check. Thank you so much for that topic on sports injuries. I think you did a fantastic job considering this is the first time you spoke on this. I learned quite a bit. I'm not sure about everyone else on the line, but I think, you know, whether you're an EMS or not, I think you can take a lot out of this topic and education and, you know, really pertain to it and relate to it as it happens more often than we think.
Absolutely.
Okay, so at this time, before I let you guys go and before I open up the lines for any questions or comments, just a reminder, if you didn't hear me at the beginning, I know some of you actually signed in a little bit late, but I got you down. But just to give you another reminder, you'll have 2 weeks or until Wednesday, April 11th to complete the evaluation quiz and attendance form. And I will send that to you all concluding the webinar tonight. And this webinar has been recorded, so please look for it posted on the Michigan Center for Rural Health website under the EMS section and under EMS webinars. And again, for those of you on the line and you had multiple people at your location, just shoot me an email to let me know who was there, and we'll get you all settled. And at this time, if you want to use the chat box to ask any questions for Jeff, or if you have any comments, you can use the chat box as well. Or I'm going to go ahead and unmute the lines for those that would like to ask a question.
If you don't, feel free to contact me.
Yeah, we do have Jeff's information. Does anybody have any questions? Okay. Do we have any other comments or any concerns?
I thought it was a very good webinar, very informative.
Well, thank
Especially
you.
about the helmet that, you know, I was taught to take it off, but I didn't realize it to leave it on.
Yeah, please don't.
Yeah. I didn't realize that it kept it aligned with the helmets and the shoulder.
Yep.
The shoulder pads.
They're designed specifically that way now so that they do give good neutral position for it. So yes, please. It's really designed that way.
Good comment there.
Yes, thank you.
Anyone else that wants to ask any questions or has any comments?
Emma, this is Scott. Great seminar, and thank you very much.
Yeah, I appreciate it. I hope you enjoy these. I try to do them to make them fun for the stuff I like to do and give you guys a little more things that you don't do, but maybe things you can do, because you guys are all smart and we count on you guys to do a lot of stuff for us.
And Jeff, just to let you know, there are a couple people in the group chat that said, good stuff, Jeff, and excellent presentation.
Well, thank you. I appreciate any feedback, even if I can make it better for the next time.
Absolutely, and I would agree with that. So if, for those of you that will be receiving the evaluation, I always like to stress to please give us any suggestions or any other feedback that you would like for me to hear, and I will definitely take it into consideration, especially specific topic areas that I have not yet covered. You know, there's so many broad topics to talk about, but I know many of you really like those specific areas underneath of one of those broad topics. So please make sure you do complete that evaluation and definitely give me criticism, positive feedback, whatever it might be, whether that's about myself or Jeff. We definitely take that into consideration.
Absolutely.
Forward. So. Well, all right, everyone, thank you so much for joining us tonight, and thank you, Jeff, again, for presenting. I've taken 2 Wednesday nights out of your last 2 months for you. So.
That's all right. That's all right. I enjoy it, so I wouldn't do it if I didn't.
Yeah, well, thank you so much. I appreciate it.
Thanks. You guys have a good day. Let me know if you have more topics. I got some great PA paramedics that love to talk.
All right. I will be in contact, Jeff, for sure.
Well, the other thing is, if you some of you EMS people are on there, if you ever want to talk about the community paramedic, which I talked about last time, I maybe will talk Dr. Domeyer, Bob Domeyer, and talk to you guys a little bit about that.
Great. Yeah, community paramedicine is such a hot topic right now, and I'm actually on the state community paramedicine work group right now, and we meet once a month via conference line and in person, and that's always, you know, a good conversation every month. But it's definitely a direction of EMS that I think has a great positive outlook.
Some cool things in the future.
Definitely. I agree.
All right. Thank you, everybody. Have a good night.
Thanks, Jeff.
Thanks, Emma.